hypertension because it comes back to play in pretty much every other area of cardiovascular medicine, at least aspects of the different classes. And we'll talk about guidelines and things like that as well. We'll see how far we get, and might start the beginning of the heart failure lecture too, but certainly won't get too far into that one. But let's see where we end up with this stuff. Okay. All right, so what is hypertension? Well, generally there's some different guidelines out there, but basically your blood pressure is over 140/90. And however you want to look at it, there could be stricter goals or stricter criteria for hypertension. Like, this isn't an example that's real, but just like as a made-up example, some alternate set of guidelines that's not cardiovascular related, like maybe the American Diabetes Association could say, well, for us, we consider for diabetic patients, blank is the goal for what we consider a hypertensive diabetic. So it could change depending on what you're reading. Generally speaking, what we're talking about when we're looking at American heart, it's 140/90. It's the most common chronic disease in America. Most people will develop it at some point. You can hasten your development of hypertension via a variety of factors, but most people just by aging will get hypertensive into their elderly years. It's just going to happen for the majority of people once they get older. So as far as risk factors go and what we're trying to prevent here, they call this the silent killer for a good reason. I'll show you some stats on the next slide. But for example, a 20/10 millimeter of mercury increases in systolic or diastolic equals a twofold risk of CV disease. 31% of patients actually have their adequate control. So it's a disease that's not managed all that well, and a lot of it's because people don't really necessarily do much about it until they have other complications. By that time, it can be a little bit too late to do anything, or you can try and mitigate some symptoms and stuff, but you can't really prevent those from happening once the damage is done. So what damage are we talking about? Mostly these three things. So stroke, myocardial infarction, and heart failure are the three big ones we think about with high blood pressure. Of course, there's other complications with high blood pressure, and other diseases that can cause problems with it. So COPD and high blood pressure together put you at higher risk for heart failure potentially. Diabetes and high blood pressure can put you at higher risk for diabetic complications like neuropathies and things like that. But if you keep your blood pressure in goal, you can get a 45% reduction in stroke, 25% reduction in MI, and 50% reduction in the development of heart failure. So that's why it's really important to do an easy screening. Of course, checking blood pressure is not all that complicated. And take a blood pressure at the clinic, and then you can keep monitoring people and hopefully catch it before you get to the point where you're looking at developing heart failure, developing some of the more severe complications like kidney failure, things like that. So periodic screening for anyone over 21 is recommended. Blood pressure, I mean, this is just stuff you guys maybe have talked about already, but I think it's important to reiterate that not to get too excited if you see somebody's blood pressure that's terrible right away. You should always make sure certain things were done correctly. So were they seated for a while? Did they just walk across, a really long lobby? We're remodeling our emergency department right now, so it's kind of a maze. So if your patient's walking through it, it could be kind of a long time, especially if the person's older, maybe out of breath easier, something like that. Take blood pressure twice, separated by at least 2 minutes, and then average blood pressure on 2 separate visits required to diagnose blood pressure accurately. Now, you could certainly take action on somebody if they have high blood pressure at a single visit if you're concerned about it, but technically speaking, it'd be 2 separate visits. All right, so essential hypertension is what represents about 90% of the cases. Not really one identifiable cause. There's links to a number of things such as obesity, excessive dietary salt intake over a really long period of time, and that's pretty much it. Otherwise, again, we're looking at a lot of things that get there, natural aging, and possibly some of these links, but we don't really know for sure. Secondary hypertension is rare, so that'd be the other 10% of people, and you're looking at things like primary aldosteronism, some different renal and thyroid disorders, and medication-induced, which is unusual but possible. So for the most part, we're looking at essential hypertension. That's going to be the bulk of the patients you see. All right, non-pharmacologic diet. Sodium's role in fluid retention and maintaining is important to a certain degree. So I think of sodium as something that's not harmful for most people. People who have good functioning kidneys can probably consume a fair amount of sodium and your body's just going to process it out. But if you do that long enough, the theory is that you can end up accumulating extra fluid, and if your body gets used to extra fluid on board, your vascular system compensates by clamping down a little bit, increasing pressure, and over time you can end up with high blood pressure. So sodium's a bit of a tricky one to say, is it the cause of high blood pressure? Possibly. Certainly it contributes though. So if you have somebody with high blood pressure, they should be on somewhat of a salt-restricted diet, or at least be mindful of that. And that's where a consult to a dietitian can be really handy. Maintaining a healthy body weight and caffeine intake could also kind of go hand in hand with dietitian consult, and those can be contributing factors too. Caffeine intake is usually more of a short-term response. People get elevated blood pressure, but if they're chronically drinking a lot of coffee every day, day in and day out, that can be a long-term issue as well. Exercise can help lower blood pressure. Regular exercise can keep blood pressure down. Life stressors, somebody has a really stressful job, that can help increase blood pressure if they're going through a really stressful period in their life. Smoking increases blood pressure. Alcohol use increases blood pressure over time. And chronic nonsteroidal anti-inflammatory medications can cause increases in blood pressure as well. So think about your prostaglandins as vasodilators, right? They're opening up blood vessels and doing things like that. If you're suppressing the production of those, you don't have as many of those good housekeeping prostaglandins circulating anymore, which can lead to not direct vasoconstriction, but can cause less ability of your body to vasodilate naturally, so you get increases in blood pressure. So the point is, there's a lot of things here that you can target as far as lifestyle modifications to help lower blood pressure. Oftentimes, some of these might be difficult. Can you tell somebody to quit their job because it's too stressful? I mean, how many people are actually going to listen to you? Probably very few. Smoking, maybe, maybe not. Alcohol use, moderate, maybe, again, maybe not. Exercise, diet, probably the two ones you could maybe focus on the most, I think, out of all of these. But, there's lots of things you could tweak, and it just depends on what the patient's willing to give up and what they may be willing to change in their own life. Oh, this is just a stupid meme I put in here. It's a funny joke. All right. So we aren't going to talk a lot about hypertensive emergency at this point. I have a whole module on that during emergency medicine, and it's got some different criteria. Basically, if we want to talk about very briefly urgency versus emergency. Urgency is just really high blood pressure with nothing else going on. It's like you get somebody in your clinic and their blood pressure is 200 over 120. You're like, what's happening? Their labs look good. Nothing else is really apparently wrong. Hypertensive emergency is like somebody has an aortic dissection because their blood pressure is that high. So that means there's some sort of complication associated with the high blood pressure. I work with a lot of ER physicians, well, a couple anyway. We're very adamant that you don't actually have to do anything for hypertensive urgency other than maybe adjust some medications a little bit. And you can do it mostly orally. So that's the big difference, just in a nutshell, but we'll come back to that specifically during EM and talk about that in more detail. Okay, so first step, we want to find a treatment goal before we start somebody on therapy. And so we're going to use the new guidelines, new-ish, I should say. JNC 2013 is the new set, aka JNC 8. Came out in early 2014. So it's a couple of years old now, but it's still new relative to the heart guideline world, which tends to take forever to come out with new guidelines. But it's pretty simple. If you're over age 60, you have a slightly more lax goal of 150 over 90. If you're less than 60, it's 140 over 90. The difference being somebody who's over 60 with CKD, or it says over 18 here with CKD or diabetes, but that doesn't matter because you're between 18 and 60, you're 140 over 90 regardless. So basically the only difference is with CKD or diabetes and over 60, then you target that slightly more aggressive goal of 140 over 90. So how does this compare to some of the older guidelines and why? This seems pretty straightforward. What was AHA 2007 had a bunch of different criteria for more strict guidelines, and they did some follow-up studies to this and came to the conclusion, at least the people who authored the guidelines and the expert consensus and whatnot, decided that these extra aggressive goals, the 130 over 80 and the 120 over 80, were simply not beneficial for patients. There's no positive mortality benefits and no good outcomes associated with targeting more aggressive goals. And ultimately, what you're usually getting is more significant side effects because you're pushing higher doses on patients. So you're getting more episodes of orthostatic hypotension and other side effects that we're going to talk about with some of the other medications here. But you might have providers out there, and you may work in a cardiology practice that still adheres to some of these in certain situations. Maybe you think that somebody's really high risk, so you want to target a more aggressive goal. Yeah, it's older data to support that, and we haven't been able to replicate that and say that that's actually beneficial. So again, guidelines are guidelines; they're an absolute rule. So I just want to give the caveat that you might work with individuals, or you yourself might actually target some of these goals in different places. But for the most part, we're just going with the original JNC 2013 goals, and that's the ones I would expect you to know for my exam. Okay, so 2007 was JNC 7, 2013 was JNC 8 or JNC 2013. So in between, there's these British guidelines published called NICE. And the reason I put this slide here, we'll come back to this in a little bit, is I think it's a really nice way, no pun intended, or pun intended, I guess. You have a setup here that shows you a system for which medications to prescribe at which stages. And I think it's a pretty well laid out system. I like it personally a lot, and it does fit in with the current guidelines. The current guidelines are a little more lax in this, but basically this is saying pretty much anyone under age 55 should be started on an ACE inhibitor or an ARB. If you have African Caribbean heritage or you're over 55, you'd start on a calcium channel blocker, and then you're going to add whichever one you didn't start on as your secondary agent, which is right in line with the current guidelines, which are on the next slide. So these are the ones from JNC 2013 that pretty much say the same thing, just it's a little bit more complicated. It gives you some more scenarios on here. And certainly I don't care that you know a lot of this. I'm not going to say, well, you have a person with, I'm not going to try and trick you with like ages and diabetes and stuff like that, but I'm going to harp on a couple of common themes within the guidelines and why we pick certain medications with certain comorbidities. So for example, with diabetes, almost everyone should be on an ACE inhibitor or an ARB because they're renally protective. So that's something to remember. And it's in the guidelines here as well. But I'll point you down to this second from the bottom here. So it says to initiate thiazide type diuretic, ACE inhibitor, or CCB alone or in combination. And it's the same thing for somebody who they've deemed black here. And they only restricted the ACE or ARB. However, this is where it gets a little tricky, and this is the same thing with the NICE. Remember, they start the same group without the ARB. So the big difference with your current guidelines, the JNC 2013 and NICE, if you're comparing these two, is that you add diuretics as a first-line therapy option, whereas NICE would say, let's reserve diuretics for third line. And I'll talk about why I tend to agree with NICE personally. And I would reserve diuretic therapy for later in a little bit. But again, all those are considered okay to use for first line. So you have three choices. For African American patients, you can skip the ACE inhibitor, but we still use those commonly in that patient subpopulation. And it just isn't considered a first line. So for some reason, they don't respond as a ethnic group, don't respond as well initially to that medication class. Compared to the other two. Okay, so that's pretty much the guidelines in a nutshell. We're going to come back to this and talk about this again after we talk about the drugs. This second slide on here shows how you would add different therapy, and we'll streamline this for you a little bit here. But again, I think NICE makes it very, very clear. It's easy, and I like it. So you have a very simple way to consider your first three major classes, your ACE inhibitors, calcium channel blockers, and D for diuretic. And then on step 4, it says maybe adding a beta blocker, alpha blocker, or considering getting an expert consultation at that point, which is pretty much in line with the current guidelines. It just says it in a lot fewer boxes and words, I think. Okay, compelling indications was a big part of JNC 7. Oops. And it hasn't really changed much. So compelling indications are still compelling indications, and I'll talk about why this makes sense. But when we get into some of these things like heart failure patients, we'll talk about there's lots of mortality benefits with certain medications. So it's not necessarily like we're targeting blood pressure goals with a heart failure patient. They're just going to be on these medications because of their disease, and they happen to lower their blood pressure too. So it's important to separate them out a little bit, but most of these patients with these diseases are going to have some form of hypertension on board too. So when it comes down to this specific lecture, we're talking about two different things. We're talking about the medications used to treat high blood pressure, which also apply in a lot of these other diseases as well. And we're talking about treating primary hypertension. So two different categories. So if somebody just has hypertension, we don't really care about any of the rest of these compelling indications. We only care about this. You could come back to this and say, oh, this person has diabetes, so what are the drugs that maybe are better? Well, pretty much all of them are fine. What about heart failure? Which ones should they be considered to be on? So, and we're going to go through those in more depth here. Okay, first major category, drugs that manipulate the renin-angiotensin-aldosterone system. These are going to be your ACE inhibitors and angiotensin receptor blockers, or ARBs. So you have a couple different mechanisms, and this is all going on in the kidneys. And you have two major drug classes here that are pretty much doing the same thing. So up here you have angiotensin that gets converted to angiotensin 1 by renin, which gets converted to angiotensin 2 by angiotensin converting enzyme, or ACE. A very nice name that tells you exactly what the thing does, right? So angiotensin 2 is considered to be a problematic, non-friendly, non-hypertension-friendly neurotransmitter, neurohormone in the body. And so it does cause vasoconstriction, and it can increase blood pressure on its own. And with unbound hypertension and increased problems in the kidneys, your body's natural mechanism is going to be to release this. And in periods of stress and short term, it's fine. But chronically, angiotensin 2, with a lot of it floating around the systemic circulation, can cause a lot of problems. And over time, you get an increase in blood pressure. So we try and block the production and conversion of that with ACE inhibitors. Angiotensin receptor blockers, or here they call them AT1 blockers, the same thing as an ARB. An ARB actually blocks the angiotensin receptor so that angiotensin 2 can't do anything. And then that's basically the same idea, it's just working on a slightly different mechanism. So you're really doing the same thing, which is why ACE inhibitors and ARBs are considered interchangeable for the most part. We don't use them together in any situations, but they've done studies on that, and they aren't shown to be beneficial together. But yeah, they are interchangeable. Yeah.
So you said the AT1 blockers are the same as ARB?
ARB, yep. They just use a different nomenclature on this slide. One thing I'll point out here is that bradykinin is a separate pathway here that also gets degraded by angiotensin converting enzyme. If you block that, what happens is you can get some additional effects with an ACE inhibitor. So bradykinin doesn't degrade naturally. You get a little bit more bradykinin circulation, which is a natural vasodilator. It's thought to, even with heart failure patients, have what we call anti-remodeling properties because it produces the release of nitric oxide, which is a natural vasodilator. And when we talk about anti-remodeling, I'm jumping a little bit ahead to heart failure, but heart failure patients tend to get ventricular dysfunction and their left ventricle tends to balloon out. So over time, if you can manage the heart failure, the idea is that the heart remodels itself and sort of shrinks back up and builds more of a thick muscle wall as opposed to this thin atrophied muscular wall. And nitric oxide is thought to maybe be responsible for that. So we'll get into that debate a little bit more during heart failure, but there's some people out there that think that because ARBs, you'll notice, don't have any effect on bradykinin. Bradykinin is going to degrade naturally with the ARB. ACE inhibitors might have a slight advantage over that, but that's just a theory. So keep that in mind in the back of your head for now. But again, jumping the gun a little bit with these drugs. Yeah.
So ACE inhibitors block bradykinin more than ARB as far as degradation?
They block the breakdown of bradykinin, right? So you get more circulating bradykinin.
And you want that?
It's thought to be beneficial, right? It also has some side effects with it, which we'll talk about here in a second. Okay, so we talked about our ACEs and ARBs. You might have noticed that on this slide there is a direct renin inhibitor. There's one drug on the market like this. We'll talk about it very briefly. It's rarely used. And there's aldosterone antagonists, which work on aldosterone receptors. And we'll talk about why we don't really use those in hypertension very much. They aren't very effective antihypertensives. So really for antihypertensives, ARBs and ACEs are our big drugs here. So starting with ACEs, ACEs all end in pril with their names. They're pretty easy to identify and pretty much first line for almost any situation. So when you look back at our compelling indications, there's very few that ACE inhibitors aren't indicated for. They're either first or second line depending on race per all the current guidelines, and they're just generally well-tolerated medications. Biggest class-related side effect is a cough. And so back to the bradykinin increase, there's thought that that's causing some sort of either inflammatory response or reflex in the lungs. It's causing a cough. So sometimes 5 to 10% of people will get like a dry, non-productive cough that's not associated with any type of illness on their ACE inhibitor, and it's usually class related. There's nothing really you can do about it other than switch them. And so that's where ARBs come into play heavily, because they work the same way. Theoretically, they don't have the cough associated with them because they don't mess with bradykinin degradation at all. So that's the theory behind the cough and why we switch people from an ACE. But for the most part, you're going to start almost everybody on an ACE inhibitor. And the reason is because we have used these a lot longer than ARBs. ARBs are slightly newer drugs, and all the evidence out there in the literature is based on ACE inhibitors. There's some evidence solely based on ARB, but when we talk about mortality benefits and stuff, when we move into heart failure, all that data is based on ACE inhibitors. And so we're making a bit of a leap of faith saying that ARBs do exactly the same thing when they really aren't exactly the same drug. But the cough conversion is a real thing that happens with ACE inhibitors, and people will get really annoyed by it. And so common practice is to switch them to an ARB. So don't think that you can't do that. It's perfectly acceptable. I'm just giving you sort of the background behind, you know, some of the controversy with that. Angioedema is the other thing that ACE inhibitors get. They get a bad rap for. You guys talked about angioedema. I don't think I realized. So angioedema is kind of like an anaphylactic response. Your mouth swells up, usually throat and tongue swelling. Lips too. Sometimes people get mild versions. Sometimes people get such a big inflammatory response that they have to be intubated. There's other issues with it as well, but it's a rare side effect. The problem is ACE inhibitors are probably one of the most common medications prescribed in the world. So if you take all the millions of people on them, you're going to see it more often simply because of the massive volume of people that are on it compared to maybe other drugs that can cause angioedema that you don't see it as commonly with. It is quite rare, so it's not a reason not to prescribe it. But once somebody has had angioedema on an ACE inhibitor, you're actually pretty much done with this class altogether. We'll talk about the renin inhibitor, which you could maybe try, but you don't try ARBs in those patients either. There's a slight cross-reactivity chance, and it's a severe enough reaction, possibly fatal, that we don't want to mess with that. So that's problematic, but again, very rare. Renal dysfunction, I just said that these are renally protective, so you guys are like, what are you talking about? They are, but if you're dehydrated and there's some other factors involved, you can possibly hurt your kidneys with the mechanism of an ACE inhibitor. We're going to go into a lot of detail on that during our renal lecture specifically. We'll come back to ACE inhibitors a little bit and talk about acute kidney injury. But for now, just know that with certain things, specifically dehydration and maybe other medications on board, you can put your patient at risk for renal dysfunction. But for the most part, they're kidney protective, and we're going to put them on all our diabetic patients, and pre-CKD or early CKD patients are all going to be on ACE inhibitors for that reason. Hyperkalemia, you can see transient potassium elevation with this. Usually it's not problematic at all. And you can also see maybe some BUN serum creatinine elevation. It's very mild, very transient as well. No issues there, not causing any kidney damage directly unless you see a massive, a really significant increase in serum creatinine. So our beneficial effects, we get a suppression of angiotensin II, like we talked about, and remember, decreased bradykinin degradation. And overall, if you take out the cough, very well tolerated, very highly effective. Even with the cough, you still got 90% of your population is going to do quite well on an ACE inhibitor. Okay, these are the drugs. Lisinopril is by far and away the most commonly used ones. Why? I'm not exactly sure. It might have been the first one that was a once daily medication that came out. However, it doesn't have that long of a half-life. Its half-life's like 18 hours. So some clinicians will argue that to really get appropriate 24-hour ACE inhibition, you should be dosing it twice daily. So we do see this done. It's more of a fancy heart failure thing, but for hypertension, once daily should be plenty for most people. All these other medications are fine to use. There's no real advantage of one over the other. But some of them are brand name, like Altace or Ramipril only comes as a brand name product. So it's going to be quite expensive. Captopril and enalapril are dosed several times a day, like 3 times a day. So most patients aren't going to want to do that compared to lisinopril. So lisinopril takes an advantage. It's cheap, generic's been around a while, and it's mostly once daily for most indications. That's why we see it used commonly. But no advantage with side effects with one or the other. They're all the same class, same type of medication. Problems, contraindicated in pregnancy. So there's one for you. We don't use these in any type of preeclamptic situation or eclamptic situation, these other medications, which we'll talk about during OB. So pregnant patients who have hypertension, no ACE inhibitors. Again, I mentioned this renal thing, and I drew a little diagram here, and I guess we'll talk again more about this during CKD, but the way that this works in the kidneys is that you have your efferent arteriole can get naturally constricted due to various situations, and with an ACE inhibitor, it can be dilated out a little bit more. And that's the effect of not having angiotensin II there to constrict that exudating arteriole from the glomerulus. And the reason this is nice and protective in most patients is because it keeps your system flowing and open. If you constrict that side of it, you can end up with some increased pressure there and kidney damage. And so the problem gets to be when you constrict both sides, then you kill your kidneys. So that's where acute kidney injury comes in. So just ACE inhibitors alone are actually quite nice and protective by themselves. It's when you dehydrate that other side, and so you don't have enough flow going into it, or you give somebody too many ibuprofens, so NSAIDs can cause acute kidney injury too. And so I'm getting ahead of myself. I'm giving you a little teaser for the acute kidney injury lecture, but basically NSAIDs and dehydration will affect that other side and decrease your flow. And if you're decreasing your flow in on one side and you're vasodilated on the other side, your glomerulus can't keep pressure and can't do anything. And then you end up with a damaged kidney. So that's the theory behind it. Well, we'll come back to that. That's not a big part of this lecture, this module. We'll come back to that in more detail next module. All right, ARBs. So again, generally considered interchangeable. Cough is really rare, so converting somebody over, you should really be able to eliminate the cough of an ACE inhibitor. Same side effect precautions as far as like kidney injury, pregnancy, same stuff there. Angioedema is about a 10% cross-reactivity, so that's a high enough percent that we don't like to convert people. There's some maybe evidence that patients with slightly elevated serum creatinine or diabetic neuropathy might do better on a drug like this, and it's not really well established, so it's just some theoretical information there. We don't use these in combination. Like I said, they've done some studies to see if there's a possible synergy here, and there might theoretically be. If you think about it, you're working on two different systems, but they haven't really found any good benefit with combining the drugs except for more increased side effects with the two medications. And I've talked about the data. So data is available for ACE inhibitors mostly, almost exclusively actually. So these drugs all end in arton, and the two top ones are the ones you're going to see very commonly, losartan and valsartan. Both of those two are generic. All the rest are brand name only. So you're going to see a massive price increase compared to these first two. Losartan's the most common one because it's been generic for several years. Valsartan went generic recently, but it's still very useful. So a lot of people think that losartan is the least potent, and that's the biggest difference. However, it's not really enough data to say if it's really a more inferior drug or not. No one knows that for sure, but it is thought to have more of a potency issue, where valsartan is thought to maybe be a little more potent. So I think we're starting to see maybe a shift to more valsartan use now that it's generic, but you still see quite a bit of both. The other ones are used occasionally, but again, they're pricey. And as we see some of them go generic, we might see more use. But there's a question of why would you really use them unless you're, I don't know, you could maybe try and maybe you're getting some response off valsartan and you're like, well, maybe I'll try a different one, or maybe you have a provider you're working with, or you yourself have had experience with one that's worked well. But for the most part, most people, like 95% of people, are going to fall into these two categories probably. Okay, direct renin inhibitor, there's only one drug on the market. It's called Aliskiren or Tecturna. It's brand name, once daily option. Has similar effects on hypertension as other RAS drugs, but it's also got similar side effects for the most part. The question with the big one is, do you use this in somebody with an angioedemic response? And I think that the jury's a little bit out on that. Where I have seen it used in patients are heart failure patients who are not maybe well managed with other medications. The thing about heart failure treatment is that you get such a good response with, or you get such high mortality benefits with an ACE inhibitor, that the idea of not touching that system at all pharmacologically is problematic. So if you have somebody with angioedema, I have seen them try Aldosterone as an option for those patients, but it's not widely done. And certainly for essential hypertension, if you had angioedema, you'd probably skip it altogether.
What's RA?
That's the renin-angiotensin-aldosterone system, or RAS. Yes.
So with angioedema, what is a normal alternative?
There isn't one in this class, really. So you basically just go to other antihypertensives. Aldosterone antagonists, not going to talk about these a ton right now. They aren't really used for hypertension. They cause some diuresis, but they're mostly used for heart failure, so we're going to come back to them then. Sometimes considering potassium-sparing diuretics is what they're also referred to as well. Their mechanism, they compete with aldosterone in the distal renal tubules, so you get increased sodium and water excretion. So they're basically just a diuretic as far as our purposes go for hypertension. And they're a weak one at that, so we don't really have much of an advantage for them. And we'll come back to these guys more during heart failure and talk about their place in therapy. But for now, just I wanted to mention them because they're part of this system. All right. That's a good bridge into diuretics themselves. So diuretics are just removing fluid from the body, basically. They have some other advantages theoretically, but for the most part, that's what they're doing. They're getting rid of excess fluid. So we can use them for a number of different tools for different diseases. Thiazides being the primary one for antihypertensive management. So we'll come back to this slide a little bit in conversation here. But thiazides are our historical mainstay hypertension treatment. They're one of the first antihypertensive drug classes developed, and still a very commonly used one today. The doses have decreased substantially over the last several years. It seems like more literature came out to say what's half the dose, and we're still getting the same response. So the point being is that if you're increasing thiazide diuretic doses, you get significantly diminishing returns every time you double somebody's dose. You don't get a good linear response with it. You get your most bang for your buck with your lower doses. It inhibits sodium resorption in the distal tubules, so sodium excretes more, water follows sodium, and you lose fluid that way. You get a little bit of increased potassium and hydrogen ion excretion as well, so you can get slightly hypokalemic. You can get hyponatremic as well with these medications, so electrolytes are important monitoring. You can also retain calcium, which can be good for osteoporosis patients, can also put you at slight risk for kidney stones as well. So it's one of the medications that can cause that. Maybe cause some secondary vasodilation outside of the kidneys. And how that exactly works, people aren't sure, but there's thought to be maybe some more things like afterload reduction on the heart, and we don't really know how that happens, but it's thought to cause that as well. So adverse effects, pretty much the big one is frequent urination, and this is why I like the NICE guidelines more than the current ones, because they're putting this as third line, which is personally where I would place it, because I mean, maybe you get somebody who tolerates the urination just fine, but most people it's going to be a pretty inconvenient side effect. And I just feel like ACEs or ARBs, calcium channel blockers, have a better profile overall. So why expose your patient to something that's going to be pretty inconvenient for them if they can do something differently? Now, if you've got them on 2 agents already, sure, it's a good add-on, but I think this should take a back seat. It is cheap, it is effective. I'm not trying to downplay its role in general, but I would, personally, choose something else for first-line therapy. There was this famous trial, I don't know if you've heard of it, it's called ALHAT, and it was when amlodipine first came out as a brand name Norvasc calcium channel blocker. It was expensive, and it was touted as this new great blood pressure drug. It's a good blood pressure drug, but somebody came out with a study called ALHAT showing that low-dose thiazides was as successful as amlodipine and lisinopril lowering blood pressure to goal. This is one of those older trials when they're saying, let's take the cheap old drug and compare it to the newer, more expensive ones. This is years ago now, and then see about what's better, what's worse, and they found out that, yeah, they're all pretty much equivalent with each other. So that was sort of a landmark trial, and still you can see it reflected in the guidelines today that we don't have an advantage technically over one or the other. However, I would say from a side effect profile, the ACE inhibitor class and our class, calcium channel blockers are going to be better tolerated for most patients. All right, hydrochlorothiazide is the one that should be considered for hypertension. It's most commonly used. It's dosed anywhere from 12.5 to 50 milligrams a day. Remember I talked about diminishing returns. If you ever see somebody at 50 milligrams of hydrochlorothiazide, it's probably too much. I don't know. I think you should question whether they're getting benefit from that or not. And they could just be wasting more electrolytes than you're getting benefit for as far as hypertension. Chlorthalidone is another thiazide diuretic that comes as an IV and a suspension. It's 1 to 2 times as potent as hydrochlorothiazide, so it also comes as oral too, I should have said that. So it's not just IV and suspension. It's 1 to 2 times as potent, so this is one that sometimes people use as a more potent alternative to hydrochlorothiazide. It's longer acting, and what we see is more substantial side effects. So I don't know if you could say that chlorthalidone is any more advantageous as an antihypertensive agent compared to hydrochlorothiazide. But you do get a longer duration, a more potent drug, but alongside of that, you get the heavier electrolyte disturbances as well. I have seen at least 3 significantly hyponatremic patients in my career, like with altered mental status levels of hyponatremia due to chlorthalidone induction therapy. So it is a real side effect, rare, but still, I've never seen hydrochlorothiazide. It's just not going to do that for most patients. It's a much safer drug, I think. Metolazone is basically a heart failure drug, so you can ignore that for essential hypertension. We're not going to use it. It's a really potent thiazide diuretic that causes short-term profound diuresis, and we use it to get fluid off in a quick period of time. We don't use it for hypertension. But I wanted to mention it because it's in the same category. Yeah?
Did you say that it has a tablet as well?
Chlorthalidone?
Yeah.
Yes.
What did you ask?
They're all available PO. Yep, PO tablets. Loops, we're going to talk about these a lot during kidney and heart failure, so I'm not going to talk about them really at all here. These are our most potent diuretics from a fluid removal standpoint. They're short duration, kind of like what I just talked about with metaxalone. And again, we'll come back to these in detail during heart failure. Not useful for blood pressure management. I'll mention the non-aldosterone potassium-sparing agents very briefly. These are potassium-sparing diuretics that are used in combination with drugs. So you rarely see these used on their own, but you'll see people on combination therapy, like 2-drug regimen, 1 pill type things. So they combine triamterene and amiloride with hydrochlorothiazide a lot. The theory is that you waste a little bit of potassium with HCTZ in the, we can go back to our diagram here quick and get a visual going. Oops, where am I going here? What happened?
You went far.
Wow, I went really far. Okay, so anyway, you waste some potassium here, you retain some potassium there. That's basically what I wanted to show you. So it was like, why did you waste your time with that? Anyway, you'll see, again, these are not often useful for hypertension at all. It's a side effect mitigation strategy to keep the potassium from getting too far out of whack. But we don't really see that happen a lot with hydrochlorothiazide. It doesn't waste a ton of potassium, but if your patient was borderline low, you could consider doing a combo drug like that to add that therapy on. Okay, moving on to calcium channel blockers. This is our 3rd JNC 2013 first-line class. But only one of the 2 categories is actually acceptable for this, and it's going to be the first one. So dihydropyridines are all in one group, and they all have very similar names, vanidipine, and they act peripherally as vasodilators. Non-dihydropyridines are the 2 oddballs, and they're more centrally active, and they work on calcium channels in the heart. They're more rate control agents, so they're going to control how fast your heart beats. We use them for things like atrial fibrillation when we want to slow down the heart. Whereas dihydropyridines don't have a lot of central effects. They're pretty much just peripheral, and they're going to cause changes in blood pressure, not really changes on how fast your heart's beating. Here's a drawing of impulses to the sinoatrial node. So if you're looking at calcium channel blockers in the heart versus in the blood vessels, yes, theoretically both could do both, but if you give a non-dihydropyridine, you shouldn't see a ton of profound blood pressure changes. And the same thing would go for a dihydropyridine. If you gave it, you shouldn't really see a profound change of the rate of the person's heartbeat. You shouldn't really see any. So they work on, again, very different systems, but similar types of channels and receptors that they're working on. All right, so these are the ones we care about when we come to the topic at hand, essential hypertension. And the first one's really the one we care about the most. So amlodipine or Norvasc is a common one. It's been generic for several years. It's once daily dosing. It's long-acting. No cardiac activity that's ever been observed, really, to a substantial or clinical degree. So it's not going to touch anybody's heart rate, which is nice because a lot of the drugs, if we mess with people too much, they can get really bradycardic, and that gets problematic, especially when we add on a beta blocker, which we'll talk about here in a second. The other drugs on here are situationally useful. A lot of them were originally out as very short-acting forms, so people were taking them like 3-4 times a day. And now most of them, like nifedipine, comes as an extended release, so it's a little bit easier for patients to take. But for the most part, it's just not really beneficial. I mean, amlodipine should cut it for the majority of your patients. If you want to try the other ones, you certainly could if they aren't getting a response from amlodipine. But that's basically all I want to say about these. Nimodipine, don't know that for this test. That's a specific one that we use for subarachnoid hemorrhage. It's a really odd indication. It doesn't really have an antihypertensive effect substantially. And nicardipine comes orally, but that one's mostly commonly used IV. So we're going to come back to that in emergency medicine and critical care when we talk about hypertensive emergencies more so. But so basically, it's the top 3 that you might see used in practice for pure hypertension. All right, side effects. Peripheral edema is probably the most annoying one. People just get usually edema in their lower extremities. It's a class effect. It can be mitigated somewhat if you have people like elevate their ankles at a certain point of the day. If they have the ability to do so, that can help with that. If it's problematic, you could try switching to a different one, but you aren't any guaranteed. I would try lowering the dose maybe to half of what you're giving and see if that helps. But you don't have that guarantee. It can be a problem for a lot of people. But other than that, there's not a lot. There may be headache, dizziness, flushing. That's pretty much every drug that affects blood pressure will have those types of side effects. Heart failure. So you might hear, and we're going to talk about heart failure more, about how calcium channel blockers are absolutely contraindicated in all heart failure patients. Well, that's more for the non-dihydropyridines, the ones that more act on the heart. We don't usually, those have negative mortality benefits, heart failure patients. For heart failure patients, it's getting a little complicated, but with heart failure patients, they're on so many medications as a standard heart failure regimen that they're usually on the hypotensive end because we're trying to max out ACE inhibitor doses on them. We're trying to max out beta blocker doses on them. We're adding loop diuretics to get rid of fluid. And at the end of the day, it's difficult to imagine an actual heart failure patient that's well managed that needs an additional medication for blood pressure control. However, it is possible. In those cases, you could consider adding amlodipine or felodipine, but it'd be a really, really weird situation. So I just want to give that little caveat there because we're going to go into heart failure and talk about how calcium channel blockers are contraindicated and whatnot. This is the one exception here, but very rare situation where you need that. Metabolic, this is probably the one drug interaction I want you to remember out of this slide is that these are highly CYP3A4 metabolized. So they interfere with a lot of other metabolic pathways. And if you see amlodipine is one specifically that'll flag on a lot of, if you do like a drug interaction review on somebody, you might see that there's a competition there. So they aren't inhibiting or altering the way the enzyme processes. They're just using a lot of that enzyme. So anything else that's trying to use up that enzyme is going to have less to go around. So both drugs are going to end up seeing levels increase. So you could have increased side effects, increased hypertensive effects that you weren't seeing. Then whatever the other drug is, you might have to dose reduce that one empirically because you're just going to get too much of it. It's not going to get metabolized enough in the body. So there's a lot of guidelines actually out there for certain drugs like simvastatin's a common cholesterol medication. That one's one that's notorious for interacting with amlodipine. And there's a lot of guidelines about how do you dose reduce both of those drugs appropriately when you have them together. Because you can use them, you just have to watch your doses on them. Most of these drugs are category C, and we do use, big bug behind me, we do use nifedipine specifically in pregnancy. It's a really common preeclampsia, eclampsia drug, and one that they used for peripartum hypertension in general. So they are generally thought to be safe in pregnancy. They just aren't category A or B or whatever. Yeah.
Can we go over? We've never gone over the category.
Oh yeah. Sure. So pregnancy categories, there's so we're going to talk about this during OB in detail. Pregnancy categories technically don't exist anymore. They're grandfathering all the new drugs in with more stringent rules on what you have to put in your package insert in your guidelines as far as how to use these in pregnant patients. However, the old categories are still grandfathered in for all the drugs existing. So you're going to see them for the majority of our careers, fortunately. I think they're really nice and easy. A, B, C, D, and X. And A being the best, X being contraindicated, and everything in between. So there's different gradations. Like C basically means that we haven't seen any evidence to support that the drugs are problematic in animal models, but no one's ever studied it in human patient populations to an appreciable degree that we can say, yep, there's great evidence that this works. Almost every single drug on the market is category C, which doesn't help anyone really. So a lot of times you're relying on post meta-analysis type data to look at. Let's look at a group of patients and say, okay, all these mothers had hypertension during their pregnancy, and they all took nifedipine, and none of them had birth defects. Well, that's pretty strong evidence, but it's not prospective randomized control. We never do that on pregnant patients because of ethical considerations. So there's my 2-minute speech on the pregnancy categories, but pretty much A is always good. That means there's actually great evidence for it. There's only a couple drugs on the market like that. B means that animal models, for the most part, are showing that there's very few risks, but human studies aren't necessarily fleshed out enough for us to make a firm diagnosis. And then C is a little bit less than that. And then D would mean that animal models are looking bad, and we probably shouldn't use this in humans. It's sort of where all they fall in. So the moral of the story is there's not a lot of evidence for medications in pregnancy. A lot of it's just anecdotal, experiential, and what we've been doing for years and been successful with.
What's X?
X means that there's definite evidence that it's teratogenic.
Okay.
There's a few drugs like that. ACE inhibitors being one of them. All right, our non-dihydropyridines, I'll just mention these briefly. We're going to come back to diltiazem specifically during atrial fibrillation and talk about that a little bit more as an antiarrhythmic rate control agent. But again, these are mostly going to work centrally. I have seen a few people take verapamil for blood pressure effects. Verapamil is going to have a little bit more of a peripheral vasodilation effect, whereas diltiazem shouldn't drop the blood pressure a whole lot. I've seen patients in our ED getting diltiazem IV get their blood pressure dropped. Yes, I've seen it happen. It does happen. But at the end of the day, it's something that if you're taking it orally and you're giving regular doses of it, you probably are just going to use it as rate control and not going to see a whole lot of antihypertensive effects of it. So that's really all I want to say here. This would not be part of a treatment algorithm. I'd expect you to know for essential hypertension. I wouldn't ask you. I wouldn't get this far down the ladder where I'd be asking about verapamil. It's just that rarely happens in real life. Side effects. You still get some of the edema. Bradycardia being the bigger one. Technically, you can see some hypotension too, especially with verapamil. It can induce a CHF or heart failure exacerbation by causing some pulmonary edema. And again, these two are contraindicated in heart failure, so that's a big difference to remember. Generally, again, not useful for hypertension. So that's really all I want to say with them. They're a rate control agent, and we'll come back to them when it's appropriate. Okay, beta blockers. So beta blockers are kind of like your fourth line therapy. And you're like, why? Beta blockers are super popular, right? Well, they are. Beta blockers, I think, for hypertension management, it's sort of an old school philosophy. Back before Norvasc came onto the market, before calcium channel blockers really existed to an appreciable degree, beta blockers and diuretics were kind of the mainstay of hypertensive therapy. And then ACE inhibitors came out, and then ACE inhibitors, beta blockers, and diuretics. And then calcium channel blockers came out. Slowly, beta blockers have been moving down the pecking order. The reason being is because they aren't the best at lowering blood pressure. They do lower blood pressure. And they have the most side effects out of all the group. They're going to decrease your heart rate, which has a ton of stuff involved with it that's problematic and intolerable for some patients. So, beta blockers, we've already talked about some beta drugs, and they all have this nomenclature, right? So beta blockers are all going to end in OL. And there's a couple different ones we'll mention here, but propranolol is like the archetypical one. It's the oldest one. It's going to be a non-selective beta blocker, works on beta 1 and beta 2 receptors. And your effects here are going to be mostly cardiovascular, as you might have gleaned from the actual drug. decreasing your heart rate. But the problems are things that are sort of a downstream cascade of that. People get exercise intolerance. People get depressed and fatigued because their heart rate isn't as high as it used to. I usually tell patients if they start these and they're complaining of these side effects, or providers that approach me about somebody who's in this situation, try and give it a couple weeks and see if your body gets used to it. Maybe give it a month and see if your body gets used to it. It does happen that you get these side effects right away, you feel like crap, and then a few weeks later, as your body gets used to it, maybe you feel a little bit better. Maybe you don't, and you have to try a different class too. But it's just something worth knowing that people don't always do great on beta blockers, which is why they've really fallen out of favor in the guidelines. Both the NICE guidelines and the Courage Agency 2013 would all put beta blockers as your fourth line option for the most part. You could try giving it before bedtime, so some people are getting fatigued. That's a good strategy to give the beta blocker before somebody goes to sleep. But most of the ones we're using, pretty long half-life, so somebody's probably going to get effects throughout the day as well.
Sorry, what is impotence?
Oh, that'd be like erectile dysfunction in men or lack of libido in women. That's a less common side effect, but is a well-documented side effect of beta blockers. Let's see. So our older drugs are what we consider dirty. So by that I mean they're going to affect both beta 1 and beta 2 receptors. The newer ones tend to be more beta 1 specific. So that's the ideal. We don't necessarily want to affect the lungs. There's no good benefit for doing that, especially if you're considering like an asthmatic patient or something like that. We touched on that briefly. But in this case, the more selective for beta 1 receptors, usually the better drug. There's a couple caveats to that though. But let's talk about these in more detail here. Okay, so here's all your beta blockers. I want you to know every single one and all the differences. So I'm going to point out a couple of them, and we're going to talk about a couple more in some different contexts here. So we're going to come back to a few with heart failure. So for example, there's only actually 3 beta blockers you can use in heart failure per recent research and what's actually approved. So carvedilol, metoprolol, and only in the extended release formulation, not the immediate release, which is an interesting side note. And where's my other one? Is it even on here? I don't know if I moved it. Oh, bisoprolol. Yeah, it's up here. So anyway, there's 3 that are heart failure approved. So if you're talking about heart failure patients, you've already got 3 narrowed down, and I'll talk about those again during heart failure. But as far as blood pressure management goes, there's really only 2 to remember, and that's atenolol and metoprolol. And those are the 2 that 99% of people will be taking. Atenolol is a nice once-daily beta-1 selective drug. The only problem it has, it's renally dose-adjusted, so if you have somebody with comorbid renal disease, they might not qualify for that. But for most people who need a beta blocker for just hypertension, this is your drug. If you have any other comorbidities like heart failure, you can't use it. But for essential hypertension, beta blocker, atenolol, once daily dose. Metoprolol is another one of those. It's just universal. It really works for anything that a beta blocker is good for. Metoprolol is pretty much there. It's a BID dose medication, but it comes as extended release, so it's a once daily med that way. So there's a more convenient option for most patients. Those are both generically available. I think all these medications, with the exception of Bistolic or Nebivolol, are generic. I believe so. There might be some extended release fancy formulations out there that may be brand name, but for the most time, they're all pretty cheap, so that's a nice advantage of this class. Yes?
Did you say that for metoprolol, the extended release can be used for heart failure, but you can use both for...
Correct. Yep. Exactly.
Did you also say that there are 3 drugs for heart failure?
Yeah, the other one is this bisoprolol up here, and carvedilol, and metoprolol.
Okay.
Yep. So I've got the heart failure approved things over here, I think, for all those 3 of those. And then you're like, what about the rest of these? I don't need to know about them. Well, let's just go through them quickly. Esmolol is an IV only one, so immediately we can rule that out for what we're talking about today. That's for hypertensive emergencies. We'll come back to it. You can ignore it for the purposes of this class discussion for this point in time. Labetalol, there's nothing wrong with labetalol. It's actually a really nice IV med. It's got a fast onset PO too, so if you gave somebody an oral dose of labetalol because their blood pressure is high, you're going to see it drop within probably an hour or 2. That's pretty rare for an oral medication to work that quickly. Labetalol is really nice in pregnancy. It's got some good data with pregnancy, and it's one of the favored medications for any type of perinatal hypertensive, either just plain hypertension, hypertensive emergency. They use it all over there. So if you work in OB or any type of OB process, Labetalol is something you're going to get familiar with. Nadolol is kind of a newer, fancier one. It's non-selective, and I don't see it used all that much. I'm not sure where its role would really be. Nebivolol, or Bistolic, is trying to be fancy, and they claim that it increases nitric oxide release. When we're talking about nitric oxide, it's having some vasodilative properties. Not super commonly used. It's brand, it's expensive. Propranolol is a non-selective drug that has a lot of good use, but pretty much none in cardiovascular medicine. We don't really use propranolol for hypertension. We use it a lot in psych now as a sort of anti-anxiety medication because it suppresses the sympathetic nervous system side of things. We'll talk about that strategy more when we talk about psych and anxiety, but really not useful for cardiovascular medicine anymore. And then sotalol we'll come back to during antiarrhythmics because it's mostly, it's more an antiarrhythmic than it is a beta blocker, but it has both mechanisms. It's a dual mechanism agent. All right, got them all down now?
So basically those are for not hypertension or heart failure, so for now they're not really relevant.
Correct. So if I asked you a question on essential hypertension and beta blockers, I would only use atenolol or metoprolol for your choices.
Okay.
If I asked you heart failure, then you're opening yourself up to the heart failure ones. The rest of them, with the exception of sotalol and antiarrhythmic questions, probably won't. I don't think any of them would come up. I won't ask you about nadolol or nebivolol. I just don't think they have a good role in therapy yet or common enough to matter. Okay, questions? Here's a funny drawing. You've got the old guy who's non-selective, and the new guy is beta-1 selective, and then you've got carvedilol, who's the youngest guy, who's actually non-selective, but has some alpha activity too, so it's thought to be more special that way. So it's kind of a funny little drawing, I think. There you go. All right, let's take a 10-minute break, and we can come back and talk about managing hypertension. Okay, so we've already talked about quite a bit of this, but covered all the major classes. There's a couple other little things we'll mention here, mostly alpha blockers and a couple other oddball drugs. All right. So this is, again, the nice guidelines with our little reviews. It's the same thing as before. Again, I think it just streamlines things a little bit more than the current JNC 2013, which leaves it up for your interpretation. You could pick really any of these three would be considered good for any of these steps, with the exception of they do follow the same recommendation of the age restriction and the ethnic restriction for ACE inhibitors not being first line. That's the commonality there. Okay, but to talk about more plain terms, general strategies, we want to mix and match classes. We want to follow the guidelines. It's a good framework or reference for how we're going to start treating people, but we just want to keep people on different classes of drugs because they should work synergistically that way. Don't want to combine any one class and double up on somebody. Compelling indications are appropriate when selecting initial therapy, and usually monotherapy is best if you can. It will normalize blood pressure in like 30 to 50% of hypertensive patients, and we always want to try and maximize the dose first before you're going to add another agent. It's not good to have somebody on a ton of drugs at low doses. They aren't getting the best benefit from them. The only exception would be if you're having side effects. So if somebody's not tolerating higher doses, then sure, keep them at the lower dose if you're getting effect from it. But try and maximize that dose first. The question comes sometimes, do you ever start two drugs at once, or do you always do a monotherapy? And technically, if you have more than blood pressure more than 20 over 10 above goal, then you would start somebody on two agents right away. In practice, I don't know how much this actually gets done. I feel like unless the blood pressure is really high, I'd probably start somebody on one and then go with two, depending on how used they are to taking medications. But that could be, individual specific response and how the patient's going to feel about two medications versus one right away.
Chad?
Yeah.
Your bullet point number 2, take compelling indications into consideration when selecting, and now you have that chart back at the beginning.
Yes.
So
we're coming back to those.
we're going to be going into
Yes.
that.
Yep.
Okay.
Yep. So that's right now. So compelling indications, we talked about, these were on that chart, and we'll go through these individually as well and what we might do. The moral of the story, I think, is that ACE inhibitor is pretty much good for everything, and if somebody has some sort of comorbid cardiac problem, they're going to be desirable for beta blocker therapy. So that would be like left ventricular dysfunction, aka heart failure, if they're post-myocardial infarction, if they have coronary artery disease, all those things would probably put them at a category for a beta blocker therapy. And again, here's the chart that blocks it up. But heart failure. So why do we want low blood pressures for heart failure? Well, you get increased hemodynamic load on a failing ventricle. So if you can decrease the pressure, you decrease the work the heart has to do, and you can help it remodel itself a little bit. Order of required therapy. I'm going to go through this in more detail in the next set of slides, but ACE inhibitors, beta blockers, loop diuretics for fluid, and most patients will be on an aldosterone antagonist as well. A lot of heart failure patients are on all 4 agents, and the doses, goal doses of these are quite high, especially the beta blocker and the ACE inhibitors. So most people are going to be not tolerant of that goal dose. So it'd be lucky if you can get somebody to their goal dose of beta blocker or ACE inhibitor, in the sense of you're either going to get them too bradycardic because of the beta blocker being at too high of a dose, or they're just going to be too hypotensive to tolerate it. So the odds of needing anything else to maintain that person's blood pressure at goal under 140/90, slim to none. But remember, we talked briefly about calcium channel blockers being an option potentially with amlodipine, but very, very rare. Most of these patients, based on what they're going to be on for just being a heart failure patient, are going to have low blood pressure to begin with. Post-myocardial infarction, if we can lower blood pressure, we can prevent further ischemia, limit unnecessary workload on the heart, and you can maybe prevent the conversion of post-myocardial infarction phase going into CHF phase, which is a common start of down the road to heart failure post-MI. So therapy is very similar. It's going to be an ACE and ARB and a beta blocker are going to be required therapy post-MI. There's some other things too that aren't blood pressure related, but we'll talk about those in a couple slide sets here during the cards module. Medications, just like in heart failure, these have really high mortality benefits too. So they have proven mortality benefits that if you're on an ACE inhibitor, beta blocker, you do see a reduction or an improvement in mortality. Or sorry, reduction in mortality. I'm getting really confused here. What mortality is? Okay. Anyway, diabetes, let's talk about that. So why lower blood pressure? Well, most patients who have diabetes a lot of times have some sort of hypertension as well. They usually go hand in hand. We're talking about type 2 diabetes for the most part here. Type 1 insulin-dependent diabetes, likely not going to be as significant, but possible. But the problem is that you have diabetic patients, lots of circulating extra glucose, which can wear down blood vessels over time as it filters through your kidneys and whatnot, and all the microvasculature in your extremities. And if you couple that with a elevated blood pressure, you're pushing harder on those end areas such as the capillaries and kidneys and whatnot, and that gives you your increased damage to those areas. So we like ACEs and ARBs. They protect the kidneys a little bit, especially they've been shown to decrease albumin levels in the urine, which is a biomarker for diabetes and can be kind of a diagnostic test for how far along your diabetes is. And so that can be a preventative measure or a protective measure, and it's something that's been proven to say that this is improving how the kidneys are functioning a little bit, or at least protecting them from further decline. Thiazide diuretics are also useful. Calcium channel blockers and beta blockers are fine. There's not really, besides the ACE and the ARB, I wouldn't say that there's a compelling reason to go thiazide over CCB or beta blocker. It could be kind of either one. I'd still probably put beta blockers at the end, but guidelines and diabetes guidelines would say that you could do either one with that. Post-stroke. So pretty much everyone's going to be treated with something, whether they're hypertensive or not. Normotensive patients with the following things would be the only people excluded. So if somebody was normotensive and you could rule out their stroke as completely embolic, meaning that it's something related probably to a heart arrhythmia and not necessarily to blood pressure. So those are the two big usual causes of stroke: uncontrolled hypertension or some sort of embolic stroke where you had atrial fibrillation and you threw a clot up into your brain, or a clot moved from somewhere else and went into the brain. But for those patients, hypertension usually might not be an issue. So in that case, maybe they don't need it. And if their blood pressure is already really low, you don't want to make them hypotensive for the sake of doing it. However, the data says for pretty much everybody else, if you aren't in one of those categories, you should be on medications to control your blood pressure. JNC7 and American Heart recommended ACE plus thiazide as a combination However, newer evidence is pointing towards just ACE or calcium channel blocker alone being effective as monotherapy, and that thiazides themselves are not really effective as monotherapy. So the newer school thinking is that if you can get by with just an ACE inhibitor, that's fine for these patients. And ACE/ARB. Anytime I say ACE, I mean ACE/ARB. It's just the evidence is ACE inhibitor heavy, but you could use an ARB as an alternative in any of those cases. Combo therapy, ACE plus calcium channel blocker, was shown to actually have better outcomes than ACE plus thiazide. So the old guidelines said ACE plus thiazide is king. The new guidelines haven't really come out and said anything specific, but the newer evidence is pointing towards thiazides having less of a role for stroke patients. Okay, let's talk about some other random drugs. So we talked about our 4 major classes and sort of where they fit in. What if your patient is uncontrolled, or they're on 2 drugs and the other 2 they're having bad side effects too? So what do you do? There's a couple other things you can try. First of all, alpha blockers. So alpha blockers are a nice drug for older men with comorbid benign prostatic hyperplasia. Alpha blockers are our first-line choice or one of our first-line choices for BPH treatment, and so it's a nice dual mechanism there. It's going to decrease your blood pressure, and it's going to help with urine flow in the prostate gland as well. Alpha blockers have the largest amount of orthostatic hypotension because for some reason they suppress the body's reflex to be able to control blood pressure upon sudden changes in how you're orienting your body. And there is pretty good evidence that people will get really dizzy on these. So that's one of the probably biggest side effects to warn people about, is just be careful when you're standing up suddenly. This is an add-on therapy. This is a drug that could be really useful for older men, and I'd probably put it in place of a beta blocker for most people as like a 4th-line option. So your ACE, calcium channel blocker, diuretic first, then I'd probably use this if the patient applies to this over a beta blocker, just because you get that BPH effect. So that'd be the criteria, right? If they have BPH, it's a no-brainer with this drug.
What was BPH?
Benign prostatic hyperplasia. So just increasing the prostate.
Can you say the order again? The ACE, the calcium?
Oh, there's no real order. It's just like, if you have your major 3 minus the beta blocker, then I would say this could be a good option to add in place of a beta blocker. You could add it on to a beta blocker as well. There's no reason why you can't do that, but
so it could literally be on
it could be
5.
It could be number 4, your choice 4, as opposed to choice 5. Yep. Clonidine is an interesting drug. It's sort of on its own island. It's a centrally acting alpha-2 agonist, so it actually works in the central nervous system, and by blocking specific alpha receptors there, it causes a vasomotor outflow through the vagal nerve that creates a signaling system that decreases heart rate sometimes, and also causes a reduction or an increase in vasodilation as well. So the nice thing about this drug is a lot of people don't take it regularly, and it's a different mechanism too. So when you have somebody and you're kind of stuck, you're like, well, they're on all the major treatments. What do? I don't really want to do an alpha blocker. I don't want to make them really dizzy. Clonidine is a good one to keep in your back pocket. It's just a different drug that works quite well. It's a pretty common medication. It's got some nice advantages in the sense that it's got a really fast onset. So if you have somebody who comes into urgent care and their blood pressure is kind of high, maybe it's like 200 over 120, but they're doing well, there's no real apparent damage to their kidneys, everything's fine, this would be a nice one to give them a dose of to drop their blood pressure. You can drop it pretty quickly with just Clonidine. Yes?
How does the agonist and alpha agonist and an alpha block?
So the alpha agonist is working centrally. Alpha blockers are blocking alpha receptors in the peripheral vasculature, which is going to prevent vasoconstriction, basically. So just think about alpha blockers as peripheral. Clonidine works in the brain. It does different. It causes an outflowing of different types of. It basically is suppressing some of the effects of norepinephrine through a roundabout mechanism. Yes.
How would you know if you're not giving too much of the med versus the orthostatic effects? Do you know what I'm getting at? Like that means the blood pressure when they stand up. So how would you know if I've overdosed them?
Oh, if it's just the med.
Versus just the side effects?
I don't know. It depends on your dose, I think. Okay. So are you at a medium dose, high dose, low dose? If you're at a low dose, you don't really have anywhere to go, then
okay.
Yeah.
Let's get back to me because I forgot.
Okay.
Completely. Like, I was like,
No problem. What else? Hydralazine's one that is a kind of interesting drug, has some utility. Orally, it's not a great choice. It's a TID to QID dose medication. However, it is one of those 5th, 6th line options. You know, if you got a lot of side effects to other agents, it could work. It's more its better role is an IV product. It's a fast-acting IV medication that we can give somebody. Works quite quickly. Its other advantages in OB. So this is the one that's pretty safe in pregnancy. That's probably where you're going to see it a lot more than in general adult medicine. But every once in a while I do see somebody on hydralazine TID. The side effects I don't think are great. I think people, it's sort of, I didn't put the mechanism up here. Oh, I did. Direct arterial vasodilator. It's kind of a potent vasodilator, and so people tend to get flushed with it. They get headaches more so than your average blood pressure medications. I don't think it's all that well tolerated, and it's multiple times a day. So again, utility-wise, questionable, but it is an option that we have in our toolbox. I've mentioned pregnancy, so I just put this slide up here to review that, because it is something that we're going to come back to. So don't worry about that for this test specifically, other than just knowing that basically ACE inhibitors are contraindicated in pregnancy. That's kind of all I want you to take away from this. But in case you're wondering, oh, we said these ones are all good in pregnancy. Well, these ones are the ones that are preferred. The one new drug on this slide is Methyl Dopa, which is sort of like a Clonidine analog, and it's a weaker version of it. It's pretty much the same class. Methyl Dopa is never used in non-pregnant adult medicine. It's only used in pregnancy. Yes?
So is there ever a disadvantage for decreasing your blood pressure too quickly, like even if it's going to be normal?
Yeah, it depends. There's some thoughts that you can cause like infarction if you do that too fast, but that would be really difficult to do orally.
Okay.
You'd probably have to give somebody really high doses of an IV med to drop their blood pressure that fast.
Not like the Clonidine.
Clonidine will drop it quickly, but in the relative sense, I mean, you're talking about quickly over an hour, you might see a drop in it. Whereas if you gave somebody an IV drip, you're going to see it drop in seconds, minutes, with certain drugs. So that's the big difference. So when we talk about blood pressure drops, it's a good thing to keep in mind. And if you look at like how do you drop somebody's blood pressure safely over time, if it's an elevated blood pressure situation, they do have guidelines for that, but it's difficult to get to control. Once you give them a dose of Clonidine, it's in their system for several hours. It's like, well, what do you really do at that point? So you can monitor them, but the odds of dropping somebody really substantially with one oral medication probably pretty slim. Be conservative on your dosing, and you should be okay. Okay, so that's the last slide with hypertension. I think I do want to go into heart failure a little bit because I know I don't really. You guys are like no, but I think it'll be good.